Professor Mangat Dogra is in front of you, and he'll tell.
Thank you, sir, for this opportunity. I think we are all passionate about the subject, and we know that we have a problem in this country that this is becoming a leading cause of childhood blindness, and we also know that heavier and more mature babies are developing ROP, and it is becoming a big major problem for the public health problem. The risk factors, in fact, the basically which are relevant to us is, of course, increased survival, because Professor Azad mentioned about SNCUs. The mortality has come down, infant and more are surviving, and inadequate quality of neonatal care. Some of these SNCUs are managed by medical officers. So that is where we are. And the oxygen is 100% given. That is where we have to put a stop somewhere. And if we don't do that, I think we're going to have absolutely a fertile ground. About 800, maybe more now, SNCUs are already, every district of the country, as Sir mentioned, they are supposed to be 1,000. And there is wide variation in neonatal care. And that is what we have to look at. And of course, we have issues with the infrastructure and availability and training, what Subhadra talked just now. We need much more. So I think we did write a little editorial. I think Anand was part of this. And this is with our neonatology colleagues, two of them, one from PGI, another from US. The possible reasons are like improved survival, we already talked. But the basic problem is unrestricted oxygen usage, 100%. And we just want baby to survive some way. And that is where we have to do something. And that is why we need to include, and the model which has been propagated by Professor Azad. Of course, incidence of infection is very high, but at the same time, we come back to the same lack of awareness on the part of service providers. That is at all level. And very nice study shown by Professor Azad. I think we did change the guidelines because of some of the work which was done in our country, including Anand, which he published, which was part of his thesis. I think this helped a lot, because we have to show data. How do you change? And biggest stumbling block was neonatologists. They said we have to train, have so many babies otherwise for screening. But then look at this, what happened. 16% were more than 1750 grams. 6.5% were even more than 2 kgs. And 23% were more than 32 weeks. This is what helped us, in fact, because data from your country need to be generated. So finally, the guidelines which are from RBSK are now 2 kg, 34 weeks. And what should be done? You have to identify a single nodal person in NICU or SNCU. Who should identify babies for screening and communicate with the patient and ophthalmologist. Have somebody, because that is how you will have a much effective program. Combine screening with the visit for a neonatal problem. They usually call them for neonatal checkup. So you should also have that kind of a strategy that you should same day, because they come from far off. And documentation, of course, is more important. Do prepare wall charts. Stick them everywhere. Whom to screen, where you have birth weight, you have when to screen, how to dilate. Very important talk today here in NICU, SNCU, nursery, OPD, everywhere. And of course, this one is very important. Subhadra has given him a slogan, Tis Din Roshni Ke, that if we can screen them, you see, with before 4 weeks, I think that will be ideal. 30 days is sacrosanct. Initial screening usually in the NICU, SNCU areas. Later, of course, you would do. And who should screen? Of course, ophthalmologist, well versed with indirect ophthalmoscopy and ROP. Biggest problem was indirect ophthalmoscopy. Hardly anybody was doing, but anyway, so now more and more are into that. But now telescreening and wild field cameras are coming in a big way. I think that is the future. And we know that wild field cameras can take, in one shot, they can be taken. These are portable. You can carry it, or your technician, nurse can do it and send the images. I think Anand deserves special mention here, and we all know about his telescreening program, not only in this country, but in many countries. His model is being followed, and which he has very effectively sort of utilized for this purpose. And he mentioned earlier in the session that if the baby is sick, you can screen through the wall of the incubator. So there's no problem. It is possible. And document according to the ICROP classification. And we have a problem, I think Professor Azad has brought this point, delayed screening. They come very late at this stage when already the fold is there or mostly like this. There is a retina behind. Now, howsoever big the surgeon is, what will you do? We don't want them to go there. I think one study was done by us, another Professor Azad projected that study, and he has already shown this data. That is where we are. We have to be looking at these things. We have published both on the same subject of stage 5, and that is where we are. He already talked about it. So what should be done? Involve obstetrician, pediatrician, nurses, ophthalmologists, and parents. I think you have to involve everybody. If you don't do that, then we can't conquer it. And Indian Academy of Pediatrics, National NNF, as well All India Ophthalmology Society. IROP Society, of course, was formed with the same only because thanks to Professor Azad for that. And Government of India, of course, he involved Government of India in a big way. And we are part of RBSK, 30 diseases. He included, I don't know how he included, because it's not a congenital disease, it happens, but it was his effort. And so I would say all healthcare providers involved in the care of preterm neonates should be aware of monitoring oxygen. That is very, very important. I think we are having biggest problem with this issue. And ROP screening guidelines should be known to all healthcare providers. The mothers should be counseled. Mother is the key. You see, if you have counseled the mother about the possible complication, implication of ROP, whatever it may be, she'll come. We have seen this. We have all seen. I've been into this 35 years in the ROP, this thing. And provision for timely ROP screening is something which must be made available. SNCUs are there. We have to have this. So I think we saw this impact of ROP screening. I had given my first thesis to a candidate in 1992. And subsequently, I also gave later after 20 years and kept the guidelines same. And we wanted to look at our own data. These was prospective both and later published. You see, in the first publication, it was 47.27%. It has come down to 22.7%, despite the fact that now more smaller babies are surviving. You see, that is the impact. If you have that kind of a interaction, it is going to come down, it's going to improve. So you can see it here. And this is after 20 years we have published these two things. So premature child is not born with ROP. I think you should remember that. And screening aims to identify, at least identify a treatable disease. That is very, we have a small window. So for treatment, we need to somehow act very fast. And delay cause blindness, we have, and these are medical legal implications are huge, and economic and social burden of childhood blindness is immense. So I would say in summary or in conclusion, lack of awareness about ROP in India need to be tackled. We have to work much more on that front. That is very, very important. And neonatal care and screening programs are variable, not optimal. I think should work on that front also. More mature and higher birth babies are developing ROP, and that is how it is happening because of the suboptimal neonatal care. And delayed or no screening, poor neonatal care are responsible for increasing number of childhood blindness due to ROP. Let's all get together, have dialogue, and I showed you how much difference it makes once you have that kind of a team which was suggested by Professor Azad. Thank you very much.
Thank you, sir, for that very insightful talk and with all your years of